This is a plantar neuropathic foot ulcer, presenting with an underlying Charcot joint deformity. The patient has lost both large and small fiber sensation. Unable to feel pain or heat, they can sleep while their flesh burns, completely unaware of the physical damage. Healthcare systems frequently cover the full cost of a surgical amputation, while the mechanical interventions required to prevent that outcome remain chronically underfunded. The scope of this failure is significant. Up to 30% of people with diabetes will develop a foot ulcer in their lifetime. These wounds are not spontaneous occurrences. They are predictable biomechanical failures. While arterial circulation and infection control are necessary for tissue healing, neutralizing mechanical pressure is the prerequisite for recovery. By reversing this pathway, clinicians can shift from reactive amputation to proactive limb salvage. This diagram maps the causal pathway of diabetic foot ulceration. Sensory neuropathy causes a loss of protective sensation. Concurrently, motor neuropathy creates muscle imbalances and foot deformities. Finally, autonomic neuropathy decreases sweat production, leaving dry skin highly vulnerable to cracking. These three variables form a triad. Neuropathy, structural deformity, and repetitive mechanical trauma act in concert to destroy the tissue. Half of all patients with this level of neuropathy experience zero symptoms. The highest risk feet are entirely clinically silent. We can observe how this failure destroys tissue at the skeletal level. Source Image 2 illustrates the 4 stages of ulcer development beneath a metatarsal head. Due to motor deformity, prominent bones are forced downward, abnormally compressing soft tissue against the ground. Because of the total loss of protective sensation, the patient feels nothing. The repetitive stress of thousands of daily steps accumulates without warning. The diabetic foot does not ulcerate from a single trauma. It fails from the silent, repetitive accumulation of unfelt mechanical load. This load creates a physical response, callus formation. In the diabetic foot, a callus is a mechanical multiplier rather than a benign symptom. Initially, the skin thickens to protect itself against the high mechanical stress localized over a bony prominence. This creates a physics problem. The dense callus acts like a hard foreign body. As the foot strikes the ground, it exponentially drives pressure deeper into the soft tissue. The presence of a callus on an insensate foot increases the probability of an ulcer forming by 77-fold. Under continued walking pressure, the unyielding callus crushes the tissue beneath it, eventually causing subcutaneous hemorrhage deep within the tissue bed. This hemorrhage is the definitive pre-ulcerative lesion. It signals that surface tissue necrosis is imminent. Recognizing and mechanically neutralizing a callus before it hemorrhages offers the clinician the last opportunity to intercept an ulcer before it breaks the skin. To prevent this sequence, clinical protocols require quantifying risk factors long before mechanical tissue failure becomes visually obvious. The sensory baseline is established by testing for a loss of protective sensation. Clinicians use calibrated instruments, applying a 10-gram Semmes-Weinstein monofilament or a 128 Hz tuning fork to the toes. Next, the vascular baseline is secured by palpating pedal pulses and measuring the ankle brachial index to rule out severe local ischemia. An ankle brachial index between 0.9 and 1.3, combined with a toe brachial index of 0.75 or higher, largely excludes severe peripheral artery disease. Once neuropathy and blood flow are mapped, the assessment must shift to biomechanical forces. Mapping high-pressure plantar zones is a diagnostic requirement. This heat map shows computerized mapping of peak plantar pressures from an optical pedographic. Intense peaks under the metatarsal heads expose impending failure sites. However, simple impression tools like the Harris mat capture similar pressure distributions in shades of gray. These 3-layer mats provide immediate visual identification of high-risk load areas, making accurate pressure mapping accessible in any standard clinic. Clinicians are also deploying ultrasound technology to measure the precise depth of subcutaneous tissue padding directly beneath prominent metatarsal heads. Measurements confirm a direct correlation. The area sustaining the highest measured plantar pressures are where the subcutaneous tissue padding is most reduced. Whether using advanced optics or a disposable impression mat, quantifying peak pressure is a mandatory diagnostic step in preventing tissue death. Once high focal pressure and a loss of protective sensation are identified, mechanical offloading becomes a central medical intervention. For managing active neuropathic ulcers, total contact casting remains the gold standard for non-removable pressure redistribution. For preventative offloading in high-risk patients, those classified as IWGDF Risk 2 and 3, standard off-the-shelf footwear is insufficient. High-risk patients require extra-depth therapeutic footwear to accommodate deformities. Source Image 4 contrasts the traumatic compression of a pointed shoe against the safe accommodation of a wide toe box. Internal length must be 1 to 2 centimeters longer than the foot. When prescribing custom-made insoles, the clinical efficacy target is precise. The device must achieve a 30% or greater reduction in peak pressure, or lower the absolute peak pressure below 200 kilopascals. This diagram outlines proper nail care, illustrating the correct straight-across cutting method. This mechanical intervention is necessary to prevent minor localized trauma in the toe box. Adjunctive non-surgical interventions are also utilized. Specialized protective padded hosiery has been proven to reduce abnormal plantar pressures during walking. Emerging invasive offloading techniques go further, injecting liquid silicone directly under high-pressure sites to artificially reconstruct the foot's internal tissue padding. True preventative care requires aggressive, quantified mechanical offloading that is tailored precisely to the patient's individual biomechanical deficits. Returning to the causal pathway, we see the complete cascade from systemic disease to local tissue death. An insensitive, deformed foot inevitably destroys itself under the pressures of walking. But offloading interventions physically disrupt this pathway, breaking the link between structural deformity and callus formation. In these cases, the complete absence of physical pain does not indicate an absence of tissue destruction. Medical systems must move from reactive wound management to proactive biomechanical assessment and rigorous pressure offloading. By treating high mechanical pressure with the same urgency as blood sugar or infection, clinicians intercept the cascade of failure and ultimately preserve the limb.